Charlie, welcome to the show.
Thank you. It's a pleasure to be here.
Well, I reached out to you because I thought it was important to get a different approach and some better information about healthcare from a different standpoint. And I'm excited to talk to you because you're doing some really innovative things that are going to help people in the long term. But before I get to Heartflow, we're going to spend the majority of the interview talking about your company and what you do. Keep in mind, we're talking to average people, and I want to do a little bit on prior to Heartflow and the time you spent in education. So my first question is, can you start by explaining what a biomedical engineer is?
Sure, absolutely. So somebody with an engineering background that is working on, really kind of working on problems, for instance, medical problems, and to help to develop new technologies. For example, biomedical engineers might have developed pacemakers, for example, or other devices that are used for a variety of different purposes. Nowadays, might be doing things and trying to create novel therapies or ways to deliver new drugs to patients, for example.
Right. So people wouldn't think about that. They think medicine and they just think specifically the doctor, but that's important too, especially when you talk about assessing the medical problems as they change over time and how people tend to get affected by certain things, or they tend to have similar challenges, and the doctors can only do so much from the specific medical standpoint. You're like an engineer, like you say, you're solving problems, right? It's like creating the better mousetrap, but doing it from a medical standpoint.
Yeah, and there are a lot of engineers that are developing. We have obviously a lot of technologies that are used to help us in healthcare, to help doctors care for their patients, whether it's maybe a medical imaging, an MRI machine, or a CAT scan, or other technologies or devices that are used to care for patients. So oftentimes these technologies are created or developed by people with a scientific background, biomedical engineering background, that are not necessarily physicians. So it's really, part of the care team, part of biomedical engineers are often helping physicians, sometimes directly, sometimes indirectly, in providing better ways for them to care for their patients.
I like that. And I think people need to understand that it's kind of a partnership, and, one or the other may not be able to solve the problem. It's a big problem, healthcare, disease, treating people in an efficient and in the best way possible. And you need those people who, I mean, like what doctor, you wouldn't think about it. We as laymen just think, oh, that's medical stuff. But very few doctors are going to, I mean, there are some that have patents and have invented things, but the average doctor is not going to spend time in surgery or oncology and say, oh, by the way, let me create a machine that can move this from here and expand this, because it's not really their wheelhouse.
Yeah, that's often the case, and as is true in so many fields today, oftentimes difficult problems are solved by teams and teams with people with different backgrounds. So it could be physicians and scientists and engineers, and this is certainly true. And the rapid development of vaccines in the COVID, it was really, these were teams, there were partnerships between people with different backgrounds. Of course, physicians are really important in
Of
that
course.
equation, but scientists and engineers and other people with other backgrounds are really important part of our healthcare systems.
Right. So I just wanted to, start with that and get people to, kind of change their mindset around healthcare, because it's much bigger than they probably even already think it is.
Yeah.
But, let's get to Heartflow. So when did the company start and how did you all come about?
Yeah, so I can maybe take a step back before Heartflow to help you understand where this came from. I actually was originally trained as an engineer and was working at before I went to graduate school at Stanford, working as an engineer for GE and working on things like major appliances or aircraft engines and many other things, applying engineering principles and computers to help design new products. I went to Stanford as a graduate student and was actually working on a project funded by the Air Force to look at airflow over fighter jets. And I happened to go to a talk by a new vascular surgeon who, by the way, who just came from University of Chicago, Chris Ahrens, to lead the vascular surgery division at Stanford. And he gave a talk called Blood Flow in Your Health. And it was in the engineering school. And the idea was, how can I get, collaborators in the engineering school at Stanford to help me solve these really difficult problems, people with the right talent. And I saw his talk, and I went to see him the next day, and I said, I don't know much about medicine, but I know a lot about engineering, and I'd really love to work on this problem together with you. So he and I, he co-advised me as my graduate advisor, together with an engineering professor, and we started working together on this interface between medicine, blood flow, vascular surgery, and engineering. And spent 15 years at Stanford working on those problems as a professor. And what I was really compelled to do was to create something that would be really a benefit to patients, to combine modern medical imaging techniques with computers to be able to understand how blood flows through our bodies, through our heart, through our arteries of our body, and to use engineering to help doctors better diagnose and treat patients. So Dr. Ahrens, Chris and I were working together at Stanford, and we were just motivated to take these new ideas and technologies out, so that they could actually be used for patients. And of course, there's only so much you can do in an academic university environment as far as that's concerned. So we decided that we would start a company and to be able to really take this technology into patient care. And that was the birth of Heartflow. We started in 2010. We were joined by a former cardiac surgeon, pediatric cardiac surgeon at Stanford, John Stevens, and the three of us got it going. And it was a mission to use this very modern, innovative technology we had created at Stanford to help patients with heart disease.
Oh, okay. So when you moved from the university to start the business, it was specifically for, heart disease and,
Yeah.
and what you work on now. That was specifically the reason why you started.
Yeah, that's right. And what I had recognized is that the tests that were available for patients at the time, the end result of it is that if you have a patient who has symptoms of heart disease, maybe chest pain, for instance, maybe they have a family history, they have a relative that had passed away before, at an earlier age of heart disease, or maybe they're diabetic or hypertensive. And they have symptoms and they go see their doctor, the doctor's got to figure out, really, is that a problem with your heart, your coronary arteries, providing the blood supply to your heart that could kill you, or is it just discomfort, or is it something else? Is it indigestion or something else that has similar characteristics to the more serious condition of heart disease? And they have to do a diagnosis. And often the way of doing that is, and you've probably seen images of people walking on a treadmill or going into a machine to get a testing or an EKG.
Mm-hmm.
And what they're trying to do is to really figure out, from the outside, looking at the patient, whether they have something wrong with their heart that could kill them, that could result in a fatal heart attack, and needs to be treated, appropriately with medicine, or maybe a stent, or maybe surgery. And it's a very, very difficult problem, because with those techniques, somebody walking on a treadmill, you're not seeing their coronary arteries, you're not seeing the places where disease is, and it's very difficult to make the best diagnosis. So what we focused on was how to use new medical imaging technique from a CT scan, CAT scan, together with some really sophisticated computer algorithms to determine whether a patient, for any individual patient, whether they had disease in their arteries of their heart that was putting them at risk of a heart attack. And to do that accurately and non-invasively, which is a real key. Because before we started, they could get that information, but they had to do what's called the catheterization and put wires into your coronary arteries. So if you incision in your groin or your arm, and then putting a catheter in and what's called a pressure wire into your coronary arteries is obviously is an invasive procedure, and it was the gold standard. But it was what we realized, there was a lot of patients ending up for that test that didn't have significant disease, and that if you could do this non-invasively, it would be a lot better for the patient than having an invasive procedure, and it would be a lot less costly to the healthcare system. So that was the problem that we went to tackle, which is kind of the central problem of heart disease, is determining whether a patient has disease in their arteries, providing the blood to the muscle of the heart, coronary arteries. And if they have disease, is it putting them at risk? So that was the problem that we started, and of course why we called our company Heartflow as well, because we're indeed interested in the flow of blood to the heart.
Right. And as I mentioned to you when we first met, that I found you by the Time Magazine article listing you as one of the 12 innovations that will change healthcare in the 2020s. So obviously, what you do must be groundbreaking. And so I want to talk a little bit more about the difference between what was being done before you started to go down that path and what it's doing now. So is it, listening to it again as a layman, it sounds like it has two primary huge benefits. One is that it's less invasive in finding out the information. So, you're not getting a bunch of tests
Yeah.
you don't need to take and, going through things that are, really end up being unnecessary, but you go through all these hurdles and all these difficulties in order to do it. But it also, correct me if I'm wrong, is better at detecting from the other side, in that you may go through that and they say you got the all clear, and maybe you don't really have the all clear. So
That's right.
maybe, so it also says, so it's both less invasive but also more accurate, or it catches what the
Yeah.
old tests don't catch.
That's exactly right. And the way to think about it is as follows. It's usually that physicians have had to choose between a test that's non-invasive but yields information that's uncertain, where you really don't know if this patient has disease. Sometimes the test would be positive, and you would take the patient to a further invasive test and you would see they don't have it. So that patient got an unnecessary invasive procedure. It was falsely positive. But the more worrisome thing, perhaps, is that sometimes a patient gets falsely reassured that they don't have significant disease, and they have it because the doctors were never able to look inside of their coronary arteries and never to ever actually see the disease directly. And that's just as troubling. So the physicians really were having to choose between tests that were non-invasive and uncertain, or tests that were invasive but more certain. So what we're really trying to do is to bridge that gap, give them the information they really need. They can see the disease in the arteries. They can get information about whether the disease is limiting the blood flow to their heart muscle, and they can do it non-invasively. So that's was really the key to Heartflow and to what we're doing, is to have what we call precision diagnostics, but have it with non-invasive data, rather than having to put wires inside of people's coronary arteries to get that information.
So spend a couple of minutes now, bragging about yourself a little bit. Let's talk about some of your successes. Let's talk about, so it's been what, 11 years. So talk about, so you brought this out, you obviously tested it well before you even got up, but people had to hear about you and see what you do, and how now with 10 years under your belt, how you can go back to the numbers now and say, this is how much more effective this is. This is what we've saved. This is what, how many people we were able to have early detection for, that the old other tests would never have captured.
Yeah. So I would say one of the things that I'm most proud of, and I feel that really differentiates Heartflow as a company, is for us, when we've had questions from physicians about does this work or would it apply to a group of patients, we've been very data driven, very clinically driven, and we'll say we're gonna work with you, we're gonna answer that question. And as a result of that, there's a very robust body of scientific data and literature and published papers about our technology. So we want to prove it, to really not just say it, but to prove that it works and to really provide the evidence. And so I think that, as I said, that's one of the things I'm most proud of. There have been over 450 medical journal papers written about our technology. We sponsor a lot of clinical research to help doctors answer those questions. And one of the the attributes of this, of course, though, is that it's hard to, medicine is a very conservative discipline in many ways. You want your doctors to be making the best decisions based upon evidence and data, and not to just go off and do something that's brand new that is completely unproven. But introducing a new technology into the healthcare system is challenging. It's difficult. The regulatory barriers, you have patients mostly don't pay for their own healthcare. We often have insurance companies, or there's Medicaid or Medicare insurance. So it's definitely a very challenging path to follow. You can think about computer internet startups that within a year or two they have their product out in the market. That doesn't happen in healthcare, because you obviously have the evidence that is required, the regulatory processes, et cetera. So I would say I'm for us though, we're most proud of the number of patients that have received our test. It's the evidence that we provide to the physicians, but once the physicians have the data and have the test available to them, it's the care that they can then provide to their patients. So we've had, I think, about 80,000 patients or so that have received our test. That's increasing rapidly right now, but we're really, really proud of that many patients who have had, and I've met many of them afterwards, they've said that this test really made a difference in my life. Perhaps it found disease that that was undetected from other tests, or spared them a trip to an invasive procedure as a result, and they could be better managed medically. So that's what drives us. What is really exciting us is that how we can be part of this, part of the healthcare, team or industry that physicians are relying upon to help them care for their patients.
Now, I brought you on because of innovation. Like I mentioned before, the whole point is to highlight this stuff, because this is really big stuff. We get excited about the new phone and 5G and all this other stuff, but how about these ways that we can keep people healthier and focus on that? But I do want to ask you a question that kind of veers to the topic that we tend to hear all the time in healthcare,
Yeah.
and that's healthcare insurance and costs and things of that nature.
Yeah.
And so we talked about medically why this is good,
Yes.
but you got to pay for it. So for the test, obviously you mentioned that there's insurance companies involved. So talk a little bit about how that's paid for. Obviously you sell more into doctors and hospitals than to the patient, but how would regular guy find out about what you do? And is it covered across the board? You mentioned Medicaid and Medicare. Can poor people get it? Is this elite? People are going to want to know that kind of thing.
Yeah, absolutely. So I think the first thing about the access to care, I think maybe 95% of patients with private health insurance have access to it in the United States. Medicare pays for it. Unfortunately, Medicaid does not yet pay for it. We hope that they will. Mm-hmm. But I would say I think most hospitals that provide the technology trying to look for tests that they can provide to any of their patients. And I expect that if a patient is uninsured, that they would hope that they were still providing these types of technologies to them. So I think that's one aspect of it. But the other side of it, from an innovation perspective, bringing again a new technology into a complex system like healthcare. We also have to think about not just the benefit to the patients and to clinical practice, because if a test was really expensive, for example, then you have to make those decisions, the difficult decisions. But what I described before is that if we have a test that the data would have been available before with an invasive exam, and we can do this non-invasively, turns out it can be a lot less expensive. Because there's a lot of patients are getting these invasive tests, diagnostic tests, which is called diagnostic catheterizations, where if they can be cared for non-invasively, it's very, very much less expensive. So in our studies, what we looked at is that this could save for Medicare patients up to $3,000 or $4,000 per patient. If you then translate that to the patients with heart disease in the Medicare population, it's billions of dollars of healthcare cost savings. So that's where we should be going. We should be looking at tests or technologies that are better for patients, but are not more expensive, but potentially in some cases less expensive. It, as we discussed when we first met, there is a possibility of, I think, providing better, higher quality care at a lower cost in our healthcare system, and that's what we should be working towards. We should be working towards, having better access to care, better quality care for a broader set of the populations. And I think that means that we need to look for efficiencies, better tests that are more efficient and lower cost, which is one of the attributes of our technology.
Wow. So in some cases, your technology is cheaper than what they would be doing all the alternatives anyway, right?
Yeah. In every healthcare system we've looked at, it's been cost savings. For example, in England, the National Health Services recently in England, we went through what's called the Innovative Technology Program, and we were one of only a few technologies that came through that. And the National Health Services in England paid for it for all of their hospitals for the first 3 years. Now, in the National Health Services hospitals, it's mandated because it's cost savings. It's better care at a lower cost. So that's true in Japan as well. When we looked at this in the Japanese healthcare system, cost savings. So we should expect, as we see in many other areas of our lives, that we can see better and better things that hopefully become less expensive over time as they reach the masses. And there's
Wow.
no reason why we shouldn't be able to do that in healthcare.
That's so funny. I am most excited about all the other stuff we're talking about, the innovation and that kind of thing. But you just brought up such an important salient point that people don't see. I think, not to get political, but the arguments, everything becomes too political. So we want to make a political statement. And I don't think these things are. We make it that way, but it's not. Obviously, there's a segment of the population that thinks healthcare should be free to everybody and everybody should be able to afford it, full stop, no matter what. And then some people say everybody should pay for their own, regardless of X, Y, and Z. But in reality, I think most people are somewhere in the middle, and you could get more people on board for paying for everything if it's efficient. The problem is people understand how government has done so many other things, and they'll say, yeah, if we pay for everything, nobody would care about the cost, right? So at some point we have to, why wouldn't you want it to be as efficient, and give the best care for the best cost that you can? And I think that if you got an innovation that's saving lives, and it's saving money, that's a no-brainer. And more people should try to find avenues to kind of put those two together. And I think it's hugely important.
Well, they shouldn't be mutually exclusive to have better care at a lower cost.
Right.
What we all worry about as healthcare consumers, we worry about having our care restricted, for instance, or where we won't have access to certain things.
Right. Or somebody saying you make this amount of money, so there's a technology out there that make you healthier, but you can't have it because you don't make enough. Right.
That's right. But I think if we, as a society, I think it's reasonable for us to expect that even in healthcare, like we see in many other areas of our lives, where as products become, more developed, more mature, then you can see advances in innovation, but the average cost to a consumer doesn't necessarily go up and increase over time. If we think about a lot of other technologies we use, we've seen tremendous advances in those technologies, and they're still affordable. I mean, you look at mobile phones, for instance, the affordability of mobile phones to the masses and to everywhere internationally, for instance.
Flat screen TVs, everything, all this stuff, it gets better, it goes down. Healthcare gets better, and
That's right, but it can,
right, but it
can
should
be more efficient. And as again, consumers, whether we're getting healthcare from private insurance or from the government, it's reasonable to expect that we should be able to get better and better care, but not continuously have our cost of care go up. Right. So I think this is the challenge, that we see working in this space. And And Heartflow is an example. There's other companies certainly that are focused on this. It's often called the triple aim of healthcare. Is that how do you deliver better care for patients? Think about also better for populations, and then also things that are more affordable over time, better for the healthcare system, and more affordable. So again, these are not mutually exclusive. We
Right.
can find ways of delivering better care at lower cost.
And you mentioned earlier, let's talk about COVID and the impact that that has had on the healthcare, I guess more from the standpoint of the impact it's had on healthcare, both from how healthcare professionals have to deal with other diseases. Because that's the other thing. People forgot for a while, not so much now, but in the early stages, people forgot. It was almost to us. I get the understanding of the importance of the COVID. I mean, don't think I'm minimizing it, but people forgot that, you know, there were people scheduled for very serious medical procedures that had to wait. There were people that still woke up that had a pain, that, you know,
Right.
stabbing pain that they didn't have the night before, or they got hit by a car, or whatever. All those things that happen every day still happen. And for a while, for 2 months solid, we just said COVID shut all that down. And talk about your like you gave an
Yeah.
example of Italy and how it affected some of the people who have, you know, coronary artery disease.
Yeah, that's right. I think, of course, in the early days of COVID, we were all concerned about obviously the personal protective equipment and access to that. And I think, many people thought, okay, I don't want to go into a hospital environment because they were afraid of going into that environment and getting sick and getting, ill or contracting COVID. Of course, the hospitals pretty quickly figured out how to manage, the ill patients with this disease, versus those that were coming in for more chronic conditions. But all of us, people were scared about that, and I think the consequence, and we saw this is really worldwide, that patients, especially with chest pain, were oftentimes not going in to get care, not going into the hospital, and were literally having heart attacks at home, with the resulting impact that the patients, when they would go to the hospital, would be sicker. So this has been a real problem. Many, whether it's heart disease or cancer, for instance, in the end of the day, still in 2020, both heart disease and cancer did take more lives than COVID. But I think it was perhaps exacerbated because of the issues that people were afraid. And I do think we're in a very different situation now. And of course, the healthcare systems have adapted and adjusted to this, which is wonderful news. And patients can go back and get these illnesses cared for. But it was reported in the medical literature in Italy and Northern California and many in England, the United Kingdom, where this was happening, that there was an increase or a spike in the rate of people presenting with more serious heart conditions because they were waiting too long. So I think that's an important message, is that, not to ignore if you're experiencing symptoms, chest pain symptoms, not to ignore those. It's again, not to be taken lightly.
And, you know, Leslie, is there anything new on the horizon for Heartflow, or anything else you want to point out that you are working on, or any other innovations that you see that even if it's not Heartflow, just anything that you see the next stage of innovative healthcare?
But one of the areas we didn't talk about this, but one of the things that we do is we use to help us and to help with the interpretation of the medical image exams. We use artificial intelligence techniques, AI, and we think about artificial intelligence in many areas of our lives. In some areas, it's a little scary, quite frankly. But in healthcare, there's tremendous opportunities to help have tools that help doctors. And I think this is an example of that. But the ability to be able to extract information about a patient and their heart from medical imaging studies is really rapidly accelerating. So one of the things that we're doing, in addition to looking at the limitations in blood flow to the muscle of the heart, is to actually just directly extracting information about the disease, the atherosclerosis, the plaques, the calcium in people's arteries. and combining that information about the plaque deposits in their arteries together with the understanding the limitations in blood flow. So I think that's an area that we're going to see more and more of as we go forward, is that there's a whole new wave of technologies that are starting to have an impact on healthcare that again will help deliver to deliver better care at a lower cost, and to also help doctors, be doctors, interact with patients, to take data together from different sources and do things that only they are capable of. So to kind of take off some of the more mundane tasks in healthcare, and hopefully make the system more efficient and better for patients.
He is Charlie Taylor, founder and chief technology officer at Heartflow. Charlie, thank you for your time.
Yep, Heartflow,
What did I say?
Healthflow.
Oh, did I say Heartflow?
Yeah.
Well, see, that's the advantage of this being recorded. He is Charlie Taylor, founder and chief technology officer at Heartflow. Charlie, thank you for your time.
Thank you very much, Charles. It's great pleasure to be on your program.
I
Thank you.
appreciate it. Nastasia?
Coming on. Hey.
Hey.
That was great. I thought, nice job.
And lastly, Charlie, can you tell everyone, for the people out here who are listening and they want to know more about it and what they could say to their physician to find out more about Heartflow, tell them what they can do and how people can find you if they want to go, because I want people to know more about this.
Yeah. So you can certainly go to our website, heartflow.com, and there's a Heartflow Finder on there where you can look for hospitals in your area. But we're in about 300 hospitals in the United States right now, all over the country. And certainly go talk to your physician, talk to your cardiologist, for example, and see where we're accessible. We're accessible in most major cities in the United States and many other parts of the country.
Right. I was going to say that if you're in 300 hospitals, you have to at least be in all the big cities, right?
Yeah.
Right.
Well, as they say, all the NFL cities, right?
There you go. So if you want to go in and talk to your doctor about it, I'm sure he may have heard of it. And if not, then, you can go to the website and find out more. There's some cool videos on there that shows, a patient talking about his situation, shows some awesome, 3D video and shows how wonderful the stuff looks. And yeah, I would definitely suggest anyone go and check out the website and see all the wonderful innovations that you are working on, and, go from there. And I appreciate it. He is Charlie Taylor, founder and chief technology officer at Heartflow. Charlie, thank you for joining me.
Great. Thanks, Charles.